All right, thank you all for joining us for today's HTRC education series. Before we get started, I do just have a few notes as we move into our presentation. The presentation is being recorded and we will share it with you afterwards. Please use the chat to ask any questions that you may have during the session. And then if you would like a completion certificate, please contact us at htrc@kumc.edu. We will get that email in the chat for you as well. And then if you do want a certificate, please include your full name. That way we can get it on there correctly on the certificate. And then we do have a lot of information to share today. So questions will be monitored in the chat and saved for the end of the presentation if we have time. If we don't get to your question, it will be documented and shared in our follow-up email. So yeah, let's go ahead and get started. I'd like to introduce our speaker, Rochelle Marding. Rochelle is a local attorney who is also a registered health information administrator and a certified medical coder. Her practice focuses on medical coding, billing and reimbursement, HIPAA privacy and security, health information management, and regulatory compliance. We are so fortunate to have Rochelle here with us today, so I will go ahead and turn it over to her.
Hey, thank you, Haley. Okay, get my screen moving here. So I wanted to spend a couple of minutes today, maybe backing up before we dive into the topic on some changes in the way care management services are coded and reported and paid for rural health clinics and for federally qualified health centers this year. There's some really important things going on at the federal level with telehealth that I wanted to just touch on briefly, and then we'll dive into the topic for today. So we're going to talk about the status of telehealth, go through a little bit of the history on RHCs, FQHCs, their all-inclusive or PPS payments, and how this concept of care management, certain services became eligible for additional reimbursement on top of those all-inclusive or prospective payment system rates. And in that evolution, there have been a lot of coding changes in the way they are reported, particularly to Medicare and how they are paid. We'll talk about those, and specifically the remote physiologic monitoring, a relatively new service, at least to RHC and FQHC billing, particularly under the Medicare program. And we'll do a deep dive into that one in particular. But I want to pause for just a minute because the next couple of weeks are really important weeks for telehealth at the federal level. And a month or so ago, we talked about some changes under the Medicare physician fee schedule in 2025. And there were some really important changes that happened at the end of 2024. And the risk of certain telehealth flexibilities under the Medicare program expiring. At the 11th hour, almost literally the 11th hour, right before those were set to expire at the end of 2024, we had a resolution, we had a bill that was passed giving a temporary extension to some of those flexibilities through March 31st. And I can't believe it's already time, March 31st, to be talking about the potential expiration of those flexibilities again. But I want to spend just a minute going through what those were and what those were not. So there are certain telehealth concepts that CMS has the ability through policy and through rulemaking to establish rules and to establish policy on an annual basis. There are certain concepts that CMS does not have the authority to change that fall under the sole purview of Congress to dictate whether and how certain telehealth concepts are implemented under the Medicare program. So what we saw at the end of 2024 were certain CMS policies like audio only that was not finalized as a permanent change for the format telehealth can be delivered under the Medicare program. And so what you see on this slide are policies that CMS made. But there were certain provisions, and I struck out December 31st because the new really important deadline is March 31st, when some policies might expire at a federal level. Because during the COVID-19 public health emergency, Congress changed some of the fundamental rules for telehealth that live under the Social Security Act. And as an act, as a law passed by Congress, only Congress, not CMS, has the ability to extend those provisions, to make them permanent, or to allow them to expire. So some of the really important provisions that we're going to be watching over the next couple of weeks are originating sites, both the geographic area, rural or healthcare provider shortage areas versus anywhere in the United States where the patient is located, is one of those concepts that was made flexible through an act of Congress during the public health emergency and has continued to be extended since. That was up for potential expiration December 31st. It was continued for a brief 90-day period and is currently potentially on the table to expire at the end of March 2025. In addition to the geographic area, rural or healthcare provider shortage area where the patient is located at the time of a telehealth service, the patient in a normal pre-pandemic telehealth model under Medicare had to present to an eligible originating site. FQHCs and RHCs have always been eligible originating sites where the patient presents and receives a telehealth service from a distant site provider. But that was also waived during the public health emergency, where you see down at the bottom of that list, the patient's home has been an eligible originating site during the PHE and for the extensions afterwards. So what is on the table, kind of some of the extensions that we've seen during and after the public health emergency. Home, an eligible originating site beyond just a very, very limited subset of substance use disorder services. We had a proposed finance bill at the end of the year. We were hoping that would extend these policies for 2 years. And then what we ended up getting was a 90-day extension. Last minute package at the end of the year. But I want to talk a little bit about where we are today on some of these policies. So any place in the United States where the patient is located expired, continued, was up for expiration and will continue through March 31st of 2025, unless we get an act of Congress to extend that even further. So where we are today, and this week happens to be a really important week, we are waiting to see what Congress does with the flexibilities surrounding eligible originating site, geographically, where the patient is located, rural, healthcare provider shortage area, or patient's home, or anywhere else in the United States where the patient is located at the time of a telehealth service. We're waiting to see whether that expires March 31st, will be made permanent, or will it continue. Distant site providers of telehealth services, including RHCs and FQHCs, which have been continued through acts of Congress since the end of the public health emergency. Critical access hospitals had also been eligible distant site providers of telehealth during the PHE, but didn't make it into the post-PHE extensions from Congress and are no longer eligible distant site billers of telehealth. What we have on the table right now is a financial package that would potentially, a continuing resolution that would potentially continue some of these services for another 6 months. So not ideal, certainly, to get us even through the end of the year. This would take us into September. So what I'm showing on this slide, these are the professionals that were eligible distant site billers of telehealth services before the public health emergency. And what you don't see on that list are RHCs or FQHCs. During the public health emergency, we had PT, OT, speech language pathology. Big circle right there in the middle, we had rural health clinics, federally qualified health centers, CAHs, critical access hospitals that are no longer eligible. And then we had that extended temporarily through March 31st of 2025. So as of today, there is a continuing resolution, which is not an act to do anything permanent. It's sort of kicking the can a little bit. It's a financial package that would allow these telehealth flexibilities to be funded for an initial 6-month period. And it's part of a broader continuing resolution from Congress as a broader financial package to avoid a government shutdown. But the latest was, as of yesterday, March 11th, the House at least voted and passed the package, the continuing resolution to extend these telehealth flexibilities for 6 months. That means we've got to wait to see what the Senate does with that continuing resolution. I was really interested to see that it was actually a pretty close call on passing this financial package. This was not a vote just on telehealth. So keep that in mind too, that it was a broader financial package. But it was closer than I think a vote on telehealth policy individually would have been. And what I kind of discerned or gleaned from the way different states, different House representatives voted is that the bill was actually, or the resolution was introduced by the Republican Party to do a 6-month extension. And while the Democratic Party does tend to favor telehealth policy extensions, those that were not in favor indicated the reason they may not have voted was the concept of the way it was being passed as a continuing resolution versus a final financial package. So it was more the process than it was the underlying concepts of telehealth. So we'll have to stay tuned in the next couple of days. We'll have a lot more information on what happens for broader telehealth policy under the Medicare program, at least for another 6-month period. Okay, so back to our regular programming. Information on rural health centers and federally qualified health centers, and the way that you may be able to bill for certain services above and beyond your all-inclusive rates, your PPS rates as RHCs and FQHCs. One thing I really want to emphasize at the outset, what we're going to be talking about today, care management or care coordination services for RHCs and FQHCs, are not telehealth services the way that term is defined as a very specific benefit under the Medicare program. While a lot of care management or care coordination services are happening outside of a face-to-face visit with the patient, they have their own benefit category, distinct and separate from telehealth. And I think that's a good thing. I think that's a good thing because no matter what happens with Congress between now and the end of the month in March 31st, it means RHCs and FQHCs will be able to continue to provide and bill separately for care management, care coordination services above and beyond your all-inclusive and your PPS rates, no matter what happens with telehealth policy in the meantime. And this is dictated by CMS policy. The other benefit I think that has, the other advantage I think it has for RHCs and FQHCs, that care management, care coordination is not a telehealth benefit under the Medicare program, is that we're not limited to those very particular telehealth restrictions that Medicare has, like an eligible originating site being in a rural geographic area, a healthcare provider shortage area, whether the patient presents to a clinic or is receiving a service at home. Those rules don't apply on care management, care coordination services. So I really want to emphasize that at the outset, that we are talking about an entirely different group of benefits for RHCs and FQHCs to provide to your patients. So with the topic of care management, I also want to discuss the nomenclature a little bit. CMS is sort of moving away from calling these care management and more broadly calling them care coordination. So I'll kind of use those terms interchangeably, but I'm talking about the same group or package of services that RHCs and FQHCs can bill in addition to your all-inclusive and PPS rates. So outside of your typical all-inclusive in your PPS rates, there are very limited exceptions, like certain preventive services that RHCs, FQHCs have been able to bill separately for. And in the last probably 8 to 9 years, CMS has been increasingly creating and offering codes, billing, and payment for clinics and other professionals under the physician fee schedule that can be paid as unique benefits. They call them care management services. And slowly and increasingly, those care management, care coordination services have also been made available to RHCs and FQHCs to bill separately, like a preventive service, in addition to your all-inclusive and your PPS rates. But not all care management or care coordination services that are available to physicians and nurse practitioners billing on a fee-for-service basis under the Medicare physician fee schedule have been available to FQHCs and RHCs. So it's almost as each year when Medicare creates a policy or a benefit or a new payment for professionals under the physician fee schedule, it's either added into RHCs and FQHCs, or we have a few-year delay before it becomes a service that RHCs and FQHCs can bill separately for. RPM that I have on this slide, remote physiologic monitoring, is notably one type of non-face-to-face service that was not able to be billed separately by RHCs and FQHCs until relatively recently. And we're going to talk about that service in more detail. One thing that's good to know about the care management, care coordination services for RHCs and FQHCs is that they are an exception to the requirement you otherwise have that your services are face-to-face with patients to be an RHC visit, to be an FQHC visit that you can bill and be paid for. As these services became eligible for separate payment and reimbursement for RHCs and FQHCs under the Medicare program, the coding has evolved a little bit. And for several years, there was a very limited subset of HCPCS codes that were used to describe a wide variety of different care management or care coordination services. And RHCs, FQHCs were paid one rate. It did not matter which type of individual care management service was provided. If it fell under the scope of that HCPCS code, there was one rate, one number that RHCs and FQHCs were paid. And that methodology has been evolving over the last couple of years. Another unique concept about care management or coordination services is the level of supervision required for these services. Because these are not face-to-face with the patient, typically for an RHC or an FQHC to bill for services that are performed in part by non-qualified healthcare professional team members. And I say QHP or qualified healthcare professional to mean the disciplines of professionals that can bill an RHC visit or an FQHC visit, a physician, a nurse practitioner, a physician assistant, nurse specialist, et cetera. If certain parts of care management or care coordination are delivered by registered nurses, for example, they have to be performed under a certain level of supervision. Generally, that supervision is called direct supervision. There's kind of three levels. There's personal supervision, where the physician or nurse practitioner has to actually be in the room when a service is provided. That's not the requirement. On the other end of the spectrum, there's general supervision, where physician, nurse practitioner, physician assistant, they bill for the service and they are generally aware of an overall responsibility for how the services are carried out. And then direct supervision is kind of in the middle. And direct supervision generally means that billing professional, that supervising professional, doesn't necessarily need to be in the room with the patient, but they are physically located on site in the clinic when services are being rendered. But that has changed, particularly through the COVID-19 public health emergency. And now there's a concept called virtual presence that is a way to satisfy the direct supervision requirement. And that's available to RHCs and FQHCs providing and billing for care management, care coordination. And virtual presence means so long as that supervising provider is available to virtually intervene with the service, to have an audio-visual visit, or to otherwise jump in and help, that is sufficient to meet the direct supervision requirement. So it's almost like general supervision, except it does require availability at the time services are being provided without requiring physical proximity in the same office suite as the nurse or other clinical staff member who's helping carry out these services. So I want to look at the kind of the evolution of the coding for some of these care management, care coordination services. Prior to 2024, most of the care management services, and I've got a list of those here, they were billed using one HCPCS code, G0511, and it didn't matter if the particular care management service the RHC or FQHC provided was transitional care management, chronic care management, principal care management, or what type of care management service it was. One code, one payment amount, regardless of what service. Now, on the fee-for-service billing side for Medicare, each of these care management services has a different value associated with it and a different payment rate associated with it. So for several years, CMS would periodically add codes to this list, and they would take the fee-for-service allowable amount for each one, and I'm kind of envisioning an Excel spreadsheet. They would just add those all up and take the average, and that was the rate of payment that you would get when you billed G0511, additional, separate from your all-inclusive or PPS rates. That methodology has also changed a little bit, where in 2024, CMS applied a weighted average. So they looked at the volume of transitional care management services being billed. They looked at the volume of chronic care services, chronic care management being billed to Medicare. So they took those allowable amounts times the volume and came up with a weighted average. That became the rate that G0511 was paid as of 2024. But policy changed again for 2025. And beginning in 2025, it's the kind of little box down here. See if I can get my little annotate laser right here. Starting January 1, 2025, both RHCs and FQHCs are supposed to begin reporting the individual CPT or HCPCS codes for the exact care coordination service that was provided instead of G0511 or other, there were 2 or 3 other care management service codes that could have been reported. So that really affects RHCs and FQHCs coding practices because it's a much broader list of codes that need to be reported this year to be paid separately for your care management, your care coordination services. When we send the slides out after the session, I've got hyperlinks here. One of them is the full list of CPT and HCPCS codes that are recognized as care coordination services. RHCs and FQHCs can bill separately. And the second link that you'll have on the slides is the Federal Register document. It's a very long document, but I'm going to have you go directly to page 292. That takes each of those CPT codes and gives you the full description of each one of them that are recognized as RHC, FQHC care coordination services that can be billed separately. Now, there is a transition period. So I'm going to list out, you'll have this on the slides as well. This is the first link and just a screenshot of what those codes are. And you can see all of the different payment rates now. So the variability from, let's see, 107 down to $19. There's a very wide range in rates now that will be paid when you start reporting on a CPT code basis. So we're going to start reporting those individual CPT codes, but there is a transition period. If your systems aren't ready, if your practice is not yet ready to begin billing individual CPT codes, you can still bill G0511. There's 4 different HCPCS codes for care management that had been used prior to this year through June 30th. But July 1, if you want to be paid separately for care coordination from Medicare, have to begin using the individual CPT codes. They will still be paid separately from your all-inclusive or your PPS rates that you're billing for the clinic. It also, CMS will also recognize add-on codes, which were not recognized previously. For example, I'm going to go back a couple of slides here. If you reported chronic care management, which is based on the amount of time in a calendar month you spend helping manage patients' chronic conditions outside of a face-to-face visit. There's a time for chronic care management. There's one for 60 minutes, and then there's one for, I think it's 20 minutes. But when you provide time above and beyond that base duration in a calendar month, you can add on codes and get additional money, additional payment under the fee-for-service Medicare program. You have not been able to do that prior to this year. You reported G0511, and it didn't matter if you spent 60 minutes or 360 minutes for that patient that month. There was one payment amount. So now with that CPT level reporting that RHCs and FQHCs can do as early as January 1, no later than July 1 of this year, you can also use those add-on codes for additional time and be paid for that additional time. The other thing on the last kind of bullet on this slide that I want to point out is there has been some discussion, although not a lot of information yet, on what this means for documentation expectations for RHCs and FQHCs. Prior to this year, having such a narrow subset of codes, 4 in total, for care management services that you're reporting, the documentation expectations for each individual care coordination service may not have been as specific for RHCs and FQHCs as it has been for fee-for-service providers billing Medicare for those same services. So now, when we're reporting each of these individual care coordination services as an RHC or an FQHC, we're going to have to make sure our documentation in the medical record supports that the requirements of each of those individual services were performed, the duration of time needed to bill that particular service was performed. So I think it does likely mean some heightened documentation expectations for RHCs and FQHCs, although we don't know yet how particular CMS will be. There has been guidance from in the Federal Register when Medicare made this decision saying they encourage RHCs and FQHCs to essentially go back and read the last 8-9 years of guidance from the traditional fee-for-service billing program on the way fee-for-service providers have been expected to document these individual services as well. So this is the guidance. I put it in quotes to make sure I don't mess it up and I get it exactly right. But this is from the Medicare Physician Fee Schedule from Medicare for 2025 for those RHCs and FQHCs that need additional time to update their billing systems. They can continue to bill G0511 through June 30th. Essentially, on July 1, you need to be using the individual CPT codes for care coordination services. Now, this would not have even occurred to me, but when I read it in the Federal Register, I thought it was worth mentioning. When you switch from billing G0511 to each of the individual care management CPT or HCPCS codes, you must do that all at once. You are not to do it on a claim by claim basis. a patient by patient basis or based on the service. So we're going to bill all of the care coordination services that we could get higher reimbursement if we bill using CPT codes, and those where the individual CPT code maybe gets paid less than G0511 will continue to use G0511 through June. CMS says you don't do that. It's you switch over to individualized CPT reporting, or you stay with G0511 until you are ready to make that switch no later than June 30th. Okay, so with that change, I want to switch gears and talk about remote physiologic monitoring. And remote physiologic monitoring is a service that has been available under the fee-for-service Medicare billing program for quite some time. And its coding, its documentation, and its policies have been evolving over the last several years as it has been available for fee-for-service billing under Medicare for quite a few years. However, it only recently was added to the list of care coordination services that RHCs and that FQHCs can provide and bill separately and receive separate payment for. And now in 2025, that includes using the individual CPT codes for remote physiologic monitoring. So I want to go through this particular service, this particular benefit that we haven't talked about in as much details for RHCs and FQHCs because it hasn't been available for you to bill separately for. What remote physiologic monitoring captures is the collection of objective and quantifiable physiologic data. So this is not subjective data where I describe my mood for the day or I input, yes, I've taken my meds. Physiologic data are things like blood pressure measurement, pulse oximetry, temperature, weight, those types of measurements. And the collection of that data is done using a piece of equipment or a device that is capable of automatically, digitally transmitting the result to the provider. So this is not the patient taking their blood pressure and inputting the result. It's not stepping on the scale and inputting their weight. The piece of equipment has to be able to transmit that data to the provider electronically, digitally, automatically. Again, I want to emphasize this is not a telehealth service. It is not limited to patients in a rural geographic area or healthcare provider shortage area or patients presenting to a clinic. These are non-face-to-face services that are typically provided in between visits for a patient, or maybe after they've been discharged from the hospital or skilled nursing facility to monitor the patient in between visits and hopefully prevent rehospitalization. There's no requirement for audio visual equipment. There is a component of remote physiologic monitoring that involves an interaction with the patient, but it does not have to be audio visual. It could be a telephone call, for example. Now, remote physiologic monitoring, the way these codes are created and structured within the evaluation and management service of the CPT book means they're primarily billed by professionals who are what are called qualified healthcare professionals that are eligible to bill an RHC clinic service or an FQHC clinic service. However, they may be performed in part by members of the clinical staff team in the clinic. So we're going to talk about who those team members are in just a minute. I'm going to go through some of the specific remote physiologic monitoring codes and kind of point out some of the nuances to these codes that you need to be aware of. The first one of these, 99091, has been a covered Medicare benefit for quite a long time, but was not highly used until the development of several new RPM codes that I'll get to next. And the reason I think 99091 was not widely used even though it has been available for a number of years, is when we look in the middle of this code, it was valued and paid to be delivered by the physician, by the nurse practitioner, by the physician assistant or other qualified healthcare professional personally. Could not be done incident to their professional services. And just not many physicians, nurse practitioners, clinical nurse specialists were rendering remote physiologic monitoring services and spending personally 30 minutes of time per patient per month in a 30-day period. But the code is there if that is the way the remote physiologic monitoring program is built for your clinic, or maybe for particular patients with particularly complex situations. Like any care management, care coordination service, because you are billing separately in addition to your all-inclusive or PPS rate, patient consent is required before you begin delivering those services, because they are not preventive services under Medicare, and there are copays and and co-insurance that apply to those services. So that we need to get the patient consent and acknowledgement that they understand that they have financial responsibility for the services and want to participate in these programs. Patient consent doesn't require its own dedicated consent form. You certainly can, but you do not have to. Patient consent for any care coordination service you're providing in the RHC or FQHC can be verbal, and we want to make sure it's documented. Discussed remote physiologic monitoring with the patient, advised on patient financial responsibility, patient consents, patient agrees to proceed. We can put that in a progress note, and that's sufficient. We just need to make sure there is consent, and best practice would be to document that, whether it's a signed form or documenting it in a note so that you can demonstrate you've met that requirement. Remote physiologic monitoring services are designed to be rendered to established patients. And so generally that means we've had an established patient is one the provider has seen within the last 3 years. But for care management, for care coordination, there's a little bit more stringent rule. Not only is this an established patient, but they have been seen by one of the providers in the clinic via a face-to-face visit within the previous 12 months, within the previous year. Generally, advance consent is required. And what that means is prior to starting remote physiologic monitoring, not at the time you are beginning a care coordination service. That was waived during the public health emergency because sometimes we were rolling these things out, the first time we're interacting with a patient, and we may not have had a face-to-face visit during the previous year. That requirement was also waived during the PHE. But those requirements are back in force for care coordination services. Now, this particular code, as I mentioned, 99091, one of the catches, one of the challenges is it was not valued to be performed by clinical staff. It was valued and paid as a personally performed service by a physician, by a qualified healthcare professional. No, didn't require an order. However, it did need to be documented as part of the plan of care from a previous face-to-face visit with the provider, or maybe an interim note that this would be a good fit for patient Rochelle Marting. No particular type of device was required. There's a little bit of a caveat to that, so long as the device meets the FDA definition of a medical device. The device meaning the scale, the blood pressure cuff, the pulse oximeter. Almost any of those devices will meet the definition of a medical device under FDA. The particular device does not have to be FDA cleared. That is not the requirement. Just meeting the definition of a medical device and have the ability to transmit the values digitally and automatically to the provider. Otherwise, it's a pretty broad flexibility on what type of device is being used. Now, even before new remote physiologic monitoring codes became available within CPT and paid by Medicare under fee-for-service, there were also existing CPT codes in other areas of the code book, but I want to highlight these, but just emphasize these are not eligible care management, care coordination services for RHCs and FQHCs to bill separately for, in addition to your all-inclusive or your PPS rates. So we really have to go back to that list, that link that you're going to get when we send out the materials, to know which physiologic monitoring codes are covered. So an EKG monitoring, ambulatory continuous glucose monitoring, these are services that have been available in CPT as separate benefits for quite a while, but they are not separately payable for RHCs and FQHCs. You can still render them, you'll just not get paid separately for them outside of your all-inclusive rate or your PPS rate. So fast forward a few years, not a lot of providers were providing and reporting 99091 because physicians, nurse practitioners, physician assistants, they were not personally performing 30 minutes of monitoring and care management within a 30-day period for patients. So new codes were created, and the major distinction with this new sort of group of codes, distinct and separate from the one single prior code that was available, is that these were available for, I'm looking at 99497, in part clinical staff time. And that was really the key distinguishing factor. And the other thing that the American Medical Association did when they created these CPT codes is to break out remote physiologic monitoring into really three components. Within any given month that you are monitoring data for a patient, there is the initial setup with the patient. So we're going to look up here at 99453. This is giving the patient the equipment, setting it up with them, showing them how to use it, whether it's the scale, the pulse oximeter, the blood pressure cuff. Maybe there's an app or a program that goes with it. You're showing them how to do all of that setup and how this program is going to work. So 99453, this is sort of an educational service, generally performed face-to-face in person with the patient. Then we have a code that gives us reimbursement for the cost of the equipment. Now, it doesn't matter if you are giving a pulse oximeter, a blood pressure cuff, a digital scale, or all of those, or any other combination of equipment or medical devices. One code, one payment amount, 99454 per patient per month for reimbursement for that equipment. And usually we find that code may not actually cover your cost of equipment, but it is something to help reimburse for the cost of that equipment, and may eventually cover your cost if the patient's being monitored for multiple months. Then the third component of a remote physiologic monitoring service is the actual monitoring and the clinical management of the data that is being digitally transmitted back to the clinic. So 99457 is capturing the time within a month, whether that's clinical staff time, physician, qualified healthcare professional time. And one unique nuance is that at some point during the month, someone, clinical staff, physician, nurse practitioner, physician assistant, someone at the clinic has to have an interactive communication with the patient. That can be a phone call. It does not have to be audio visual. The patient can be at home. They could be at the grocery store. There's no specific location where the patient is at the time, because remember, these are not telehealth services, but there must be an interactive communication at some point in the month. You'll also see that these are time-based, or at least this 99457 is time-based. We have to spend at least 20 minutes of time on remote physiologic monitoring in a month. That 20 minutes does not need to be as part, how do I say this? The interactive communication does not have to be 20 minutes, but the time you spend on the interactive communication is part of the 20 minutes. So all the time spent reviewing the data that patient Rochelle's digital scale, pulse oximeter, blood pressure cuff are sending into the clinic throughout the month, we track that, and we're tracking the time we're monitoring it. We're comparing it to the care plan. We're comparing it to target goals. If Rochelle skips her weight on a day, that's part of the monitoring and the management. Rochelle, I noticed you missed the scale today, or sending reminders. All of that can be part of the time that we're counting towards 20 minutes. Subsequent to those codes being developed, providers were reporting they were spending more than 20 minutes in a calendar month on this remote physiologic monitoring. And so the American Medical Association in the CPT book created an add-on code, and CMS began to recognize this add-on code. But up until this year, when RHCs and FQHCs can bill individual CPT codes, it didn't matter if you spent 20 minutes or 80 minutes, you were only going to get payment for G0511, one rate, no matter how much time you spent. Now you can capture and be paid separately for each additional 20 minutes of remote physiologic monitoring performed for a patient in a month. I've been saying in a month, I want to hit on a couple of the things that I've highlighted in these codes, because you'll notice for some reason, and I wish I knew why, the 99454 is reported for each 30 days. That could be January 15th to February 15th. But the service to monitor physiologic parameters is reported by calendar months, the month of January, the month of February. So for some reason, the time periods are different for those two codes. Also want to point out what I've highlighted, the parenthesis S for physiologic parameters, because it does not matter if you're monitoring one parameter, blood pressure, or blood pressure, pulse oximetry, weight, temperature, or any other combination. You only get to bill 1 unit of 99454 per 30 days, 1 unit of 99457 per calendar month. You don't get to report it for each parameter that you're monitoring. And 99453, it is an initial setup, so you only bill this once in the episode of treatment of physiologic monitoring. It's just the initial setup of that device. Okay, so this just kind of compares the code that had been available for years, but was hardly ever used. It didn't require the use of a medical device, as that term is defined by FDA, which, remember, does not require FDA clearance. And pretty much any device that takes these physiologic measurements are going to meet, it's a very, very broad definition of a medical device. For 99457, this does require an order from a provider, generally because it's in part carried out by non-physician, non-qualified healthcare professionals who are involved in the monitoring. It is valued to be performed by non-physician or APP professionals, so registered nurses, LPNs, who can monitor data, reach out to the patient. It's not valued to be personally performed by physicians, nurse practitioners, physician assistants. They remain involved in the overall monitoring. Rochelle's not taking her weight measurements, and she hasn't in 7 days. So overall monitoring and measurement, but that physician or nurse practitioner is not necessarily involved in monitoring all of the data parameters that come in. They both require consent. These are non-face-to-face services that there is patient financial responsibility for. Now, a face-to-face exam, I put a question mark because there has not been formal official guidance from CMS that there has to be a face-to-face exam prior to beginning these services. But reading between the lines on the way CMS handles broader care management, that's generally the way practices have interpreted and said we will have a face-to-face visit with the patient before we get consent and begin providing remote physiologic monitoring. Now, I'm going to go back a slide because I just finished telling you that these are reported for each 30 days and each calendar month. But CPT has a funny rule about reporting time that unless a code specifies otherwise, you have met the time threshold if you have passed the midpoint. And CPT and Medicare apply that rule to remote physiologic monitoring. So even though the code descriptor says each 30 days, if you have the patient has a piece of equipment and they are monitoring parameters on each of 16 unique days in a 30-day period, that is enough to report 99454. So long as you have achieved 20 minutes of remote physiologic monitoring time across 16 distinct days in a calendar month, that is sufficient to report 99457. But that was not the case if I back up a couple of slides. For 99091, 30 days was a minimum threshold. The time is different. 99091 we just looked at had 30 minutes, where the base code that we start with, 99457, when we're providing this in part with clinical staff, only requires 20 minutes within a calendar month. Now, these are some of the other services. So 453 is our education and setup. 454 is the equipment itself. And then there is some work time RVUs that are involved in the actual monitoring service, the 20 minutes of time each calendar month. Okay, so I'm going to spend just a few minutes talking about how these are paid before we wrap up and open it up for questions. But the way remote physiologic monitoring is carried out under both fee-for-service and RHCs, FQHCs, has been a little bit of an evolution on guidance. I want to put this on the slide because if you go out and search for RPM, you may find instructions from early on when these codes were first released that are not necessarily the rules that are in effect today, because it changed almost annually from the point that they first came out and kind of lead you to where we are today. Initially, CMS said you can't provide these services incident to, meaning incident to the services of a physician or qualified healthcare professional. Well, that doesn't make sense for 99457 that is designed to be performed in part by clinical staff. So when CMS realized that, they had a technical correction around April 2019 that said, oh, sorry, our mistake. You can deliver remote physiologic monitoring incident to. Incident to requires direct supervision. Direct supervision requires the supervising physician or nurse practitioner to be in the office suite and immediately available to intervene when a service is being provided. The challenge that left for fee-for-service providers at the time, because this was not available to RHCs and FQHCs, was we want to use a vendor for this service. We want to use a vendor who has this process and this program down like a well-oiled machine, but that would mean their staff need to be in our clinic on site. So we had the next evolution of guidance was CMS saying these can be provided under general supervision, not direct supervision. During the public health emergency, there was a flexibility that allowed remote physiologic monitoring to be provided to new patients as well, in part because it was often used for patients discharged from the hospital who may not yet have presented to your clinic to establish a face-to-face visit or become established patients at your clinic, but we were monitoring them to get them out of the hospital setting, reduce exposure and interactions among patients as much as possible, and try to safely monitor them at home for signs of infection or signs of exacerbation to prevent readmission. But after the public health emergency ended, this was again required for established patients, and we can't provide remote physiologic monitoring for a new patient. They are available for both acute and chronic conditions, although we tend to see it mostly used for chronic conditions. Now that the public health emergency has ended, we have to provide we have to receive data, physiologic data, on 16 unique days within that 30-day or calendar month period to report monthly remote physiologic monitoring services. There is an flexibility for that requirement because patients might be monitored for a few days after surgery during the PHE. That flexibility was created, that's gone. So we're back to a 16-day minimum to provide and bill for those services. So that's a lot on remote physiologic monitoring, but we do have a couple of minutes left. So Molly and Haley, I'll open it back up to you if you have any closing remarks, and then if we have time for any questions.
Sure. We had one question come in. I think this may have been pertaining to the kickoff that you had with some of the updates. Clarifying what the final decision for maybe mental health provider has been seeing, if they've been seeing a patient telehealth only, do they now require an in-person visit one time? And what are the guidelines for those, especially if a patient has been seen via telehealth?
Okay, great question. So in the middle of the public health emergency, an additional benefit, telehealth benefit, was made available where patients who were being seen for mental behavioral health care services that were not also co-occurring with substance use disorder could receive telehealth services under the Medicare program from home. And no matter what happened after the PHE, home will continue to be an eligible originating site for those services. A caveat, and I do not know why, for this service as opposed to patients receiving those same mental behavioral health that do occur with substance use disorder. If they were not co-occurring with substance use disorder, Congress imposed a requirement that the patient needed to be seen in person within the 6 months preceding the first mental telehealth visit, which could be for a patient at home. That in-person visit requirement would not apply if regular Medicare telehealth rules were met. It really only would have applied for patients at home. It has not kicked in yet because home remains an eligible originating site for all Medicare telehealth services through today. We do have guidance from CMS policy, though. Once that requirement comes back into effect, which could be as soon as April 1, but it looks like at least extending through September. If you have been seeing those patients, mental telehealth services via telehealth at home through the PHE, you will not need to bring them back in for an in-person visit to continue providing those mental behavioral telehealth services under the Medicare program to patients at home when those flexibilities expire. But patients beginning kind of a new onset or recommendation that they have those services via telehealth, they will need an in-person visit in the 6 months preceding your first telehealth visit.
Thank you. One more maybe fast question before I turn it back over to Haley for wrap up and upcoming events. Can you define unique days with the billing of 16 days for RPM?
Yeah, perfect. Calendar days. And that applies whether we're looking at 99454, which it goes by each 30 days, or whether we're talking about 99457, which is the actual monitoring service, kind of the cognitive work and time that's involved. 16 unique calendar days of actually receiving physiologic data within a 30-day or calendar month period.
Thank you. Okay, I'll turn it back over to Haley.
Yeah, thank you so much, Rochelle, for all that great information, and thank you all for your questions. Let me see here. Here we go. We do have some upcoming events. So we have Dr. There we go. We have Dr. Harris and Jason Goldwater from Laurel Health presenting on the social ROIs of telehealth on March 25th from 12 to 1. And then we are lucky enough to have Rochelle back with us on April 30th, focusing on the status of Congress's financial package and telehealth policy. That's also from 12 to 1. And then we will email the recording and our follow-up resources and materials to you as soon as they've been processed. Again, if you'd like a certificate of attendance, please email us at that HTRC@kumc.edu, and we look forward to seeing you all next time.